Forum. Good afternoon, everyone. Welcome to the Health Informatics Seminars. I'm David Potenziani and will be the host today. Just a quick housekeeping announcement. Please remember that today's seminar is being recorded. Do mute your microphone while we are viewing the presentation. However, when we come to the Q&A segment, feel free to unmute yourself and pose questions or make comments to the presenters to discuss. Alternatively, you may post in the chat where I am happy to relay and perhaps even amplify your question or comments. So, Professor Kapoor.
Thank you. Good evening, everyone. We have two guest speakers today. Our first speaker, Dr. Shannon Harris, serves as lead faculty and an assistant professor in the BSHIM program at the University of Arizona Global Campus. She holds her RHIA certification and has over 16 years of experience in HIM. She holds degrees including a Doctor of Philosophy in Health Services, a Master of Business Administration, and a Bachelor of Science in Health Information Management. Dr. Harris has experience working with duplicate records, which initiated her research interests in patient identity management. Additionally, she has made significant contributions to the field through research, publications, and presentations on health information management and HIM education. Dr. Harris is actively engaged at the national, state, and regional levels of health information management associations and was honored with the 2025 Distinguished Member Award from the Alabama Association of Health Information Management. So welcome, Dr. Harris. And our second speaker for today is Dr. Shannon Hauser. She's a professor in the Department of Health Services Administration and graduate program in health informatics at the University of Alabama at Birmingham School of Health Professions. She also serves as a senior scientist with UAB's Center for Clinical and Translational Science, Center for Outcomes and Effectiveness Research and Education, and Centers for AIDS Research, and is a scholar at the Sparkman Center for Global Health. Dr. Hauser's research advances health information management and informatics by exploring how technology shapes workflows, data quality, and workflow development. Her work emphasizes digital and data literacy, informatics competencies, and the integration of tools such as electronic health records, telehealth, and mobile health to strengthen population and global health initiatives. She also examines privacy, security, and ethical challenges, along with the role of emerging technologies in transforming healthcare delivery. Dr. Hauser has led numerous projects to improve health data quality, address social determinants of health, and prepare the informatics workforce for an evolving healthcare landscape. Dr. Hauser has received multiple honors, including the 2025 UAB Distinguished Alumni Award, the 2024 AHIMA Triumph Influencer Award, and previous AHIMA Triumph Awards for research and mentoring excellence, recognizing her leadership in health informatics research, education, and professional advancement. She is also known for global leadership, serving as chair of the International Federation of Health Information Management, Education Community of Practice, and holding visitor professorships at international institutions. So welcome to you as well, Dr. Hauser, and over to you.
Thank you so much. Thank you for having us. We really appreciate the opportunity to share this work today. I am Shannon Hauser from UAB, and I'm presenting here with Shannon Harris from University of Arizona. Today, we are looking at duplicate medical records from a slightly different angle, not just about the technology or technical issues, but as something that related to how the work actually happens inside healthcare organizations. So as we know, patient records are central to healthcare data and decision making. Duplicate medical records are very important data quality issues that often gets overlooked, even though they affect many downstream processes. So in the health information world, This is something we encountered regularly. In this talk, we look at duplicate records as a data quality problem shaped by how the work happened in healthcare settings. We will share a recent study we conducted examining how organization factors, especially operational conditions, are associated with duplicate records creation, and that those patterns may mean informatics and informatics practice. Typically, one person should have one medical records within the same healthcare system. Duplicate medical records happened when two or more medical records are created for same patient, usually unintentionally. This most often occurs during registration in fast-paced environment like emergency department, where speed matters and the small name, small data entry mistakes can slip in, such as misspelled name or incorrect birthday or failed digital reverse in the social security number. Even similar names can create confusion. For example, Shannon Hauser and Shannon Harris, same first name, last name start with H. So it's very easy to see how an error could happen. These duplicates usually come from user errors, system limitations, or workflow pressures. When the records slip like that, the information or impact is much bigger than the small mistake that created. Duplicate records are not a small problem. Studies show the average rates for duplicate records, it's around 10 to 12%. And in the fast-paced area, like a ED emergency department, it's even higher. Slightly over 60% of duplicates start there. That level of duplication has real consequences. On the care side, it can mean incomplete patient history, delayed treatment, and the higher risk of clinical mistakes because information is scattered across the records. There is also a financial impact. Duplicates create billing problems, claims denies, and a lot of administrative reworks that take time and the resources to fix. And from system perspective, it hurts interoperability. When records don't match, it's become harder to share accurate patient information across settings, which affect coordination of care. The emergency department is one of the highest risk environment for duplicate records, simply because of the volume and the pace. Between 2009 and 2019, ED admissions increased by about 15%. And that growth brought larger weights and lots of workflow redesigns. To manage that pressure, many hospitals moved toward fast-track system. Instead of finishing registration at the central desk, part of that process now happen directly in the exam room, so the patient can be seen faster. So you can see from this flow here, information is collected in stages as the patient move in through the triage and into a room. The final step shows registration being completed right in the ED, not at the central registration area. So that helps with the throughput, but it also means patient data are captured in multiple places and at multiple moments. As we can see here, each extra handoff creates another opportunity for small entry errors. So why do we want to focus on operational factors? Most the conversations above duplicate records focus heavily on technology, such as matching tools, alerts, system fixes, or on the policy standards and the procedures. Those things matters, but they don't fully explain what's happening in the real workflows. What often gets less attention is the operational condition people are working under day to day. For example, a night shift registrar may be handling multiple responsibilities with fewer staff. A busy morning shift during peak admission can lead to the rush entrance. During major surges, like the COVID pandemic, which overlaps with our study period, the workload stretches both systems and the staff at the same time. Our goal from this study is to look beyond the software and the policies that focus on those real operational pressures, the human and the workflow side. To better understand when duplicate records are most likely to occur and how improvement strategies can be grounded in actual practice. I now ask Dr. Shannon Harris to talk about our study, how did we design this study, data collection, and we want to share some findings from our study.
Thank you so much, Dr. Hauser. So we conducted this study in 2 acute care hospitals within the same regional health system. These hospitals share a patient population and physician workforce, which means patients often move between sites and registration workflows are comparable. Both hospitals use fast-track ED registration, where patient information is collected during the visit rather than entirely upfront. From a health IT perspective, this setting is important because legacy patient records from multiple systems were consolidated into a single enterprise EHR, supported by one master patient index and standardized registration workflows across hospitals. That allowed us to hold the technical infrastructure constant while examining operational variation. The study period spans March 2019 through September 2020, covering 217 days and including the onset of the COVID-19 pandemic. This setting matters because fast-track ED registration occurs in a high-throughput, time-pressured environment, which increases the risk of patient identity and data quality errors, making it an ideal context for examining how operational factors relate to duplicate record creation. For this study, we focused on three core data elements. First, we examined confirmed duplicate record errors. These were not algorithm flat records, but duplicates that had been identified and validated through routine health information management processes. Second, we included work shift, which we assigned based on the time of ED admission. Third, we captured daily ED admission counts as a measure of operational volume. One important limitation is that admissions were not available broken down by shift. As a result, shift assignment was inferred from time of day windows, which is a common approach in operational and informatics studies, but does introduce some imprecision. We account for this in our analysis and interpretation. From a data governance perspective, all protected health information was de-identified and verified by health information staff prior to analysis. Each duplicate pair was labeled as Record 1 and Record 2 to support consistent comparison, and the study received full IRB approval. Together, this data allowed us to examine how operational factors, specifically shift timing and admission volume, relate to duplicate record errors within a real-world ED registration environment. So this study is guided by three related research questions that focus on when duplicate record errors are most likely to occur in the ED. First, we ask whether work shift is associated with duplicate record errors after accounting for daily ED admissions. This allowed us to examine whether timing and staffing contexts matter beyond overall patient volume. Second, we examined whether daily ED admissions, as a measure of operational load, are independently associated with a duplicate record error. In other words, do higher volume days increase the likelihood of identity errors? And third, we explored whether work shift and admission volume jointly influence duplicate record error patterns. This helps us understand whether certain combinations, such as high volume days during specific shifts, create particularly high risk conditions. Why this matters is that these questions move beyond counting errors to identifying when errors occur and under what operational conditions. That insight is critical for designing workflow-aware interventions and supporting data-driven improvement rather than relying solely on generic technical fixes. Now, let's look at what kinds of duplicate errors we were actually seeing. Across a little over 500 emergency department admissions, we confirmed 356 duplicate pairs. What stood out immediately is how concentrated the problem is. Nearly all of the duplicates were driven by name-related errors, not date of birth, not address, but patient names. Social Security number mistakes did show up, but they were relatively rare, and we didn't see confirmed duplicates tied to date of birth or address in this sample. This tells us something important. The biggest vulnerability in this environment isn't complex identity data, it's the basic information captured during registration, especially names. Small spelling differences or formatting variations are enough to split a record. So the implication here isn't just technical, it points back to workflow, how names are captured, verified, and confirmed in fast-moving registration settings. Strengthening those steps may have a much bigger impact than adding more complex matching rules later. One of the clearest findings from our analysis is that duplicate record errors are not evenly distributed across the day. The morning hours stand out. Between 5 and 11 a.m., more than half of all duplicate errors, about 57%, occurred during this shift. In comparison, the rest of the day shows substantially lower error rates, including the afternoon and evening hours. While there is some risk overnight, it is still well below what we see in the morning. This pattern aligns closely with operational realities in the ED. The morning shift often coincides with rising admission volume, staffing transitions, and multiple handoffs happening at once. Under these conditions, registration work is moving quickly, and identity verification steps can become compressed. The key takeaway here is that duplicate record risk concentrates during specific operational windows. The morning shift represents a critical opportunity for targeted staffing strategies, training, and workflow safeguards to reduce duplicate record creation. This finding looks at admission volume and duplicate record errors. What we see is a clear relationship. Days with higher ED volume tend to have more duplicate record errors. The figure helps show this visually. The top line represents daily ED admissions, which fluctuate quite a bit over time. The bottom line shows total duplicate record errors. While the error counts are much smaller, you can see that they tend to rise slightly on higher volume days. Analytically, we tested this relationship and found a modest but statistically significant association. About 3 to 5% of the variation in errors is explained by daily admission volume. So volume alone doesn't explain everything, but it does matter. From an operational standpoint, this makes sense. As volume increases, time pressure increases. Staff have less time to search existing records carefully, and small shortcuts can add up. The key takeaway here is practical. Admission surges can be treated as a risk signal. Monitoring volume and adjusting staffing or workflows during peak periods may help reduce duplicate record creation. After looking at work shifts and admission volumes separately, we then examine their combined impact. What stands out is that admission volume matters most during shift 1. When volume is higher in the early morning hours, duplicate record errors increase. In fact, admission volume explains about 5.7% of the variation in errors during shift 1. In contrast, we don't see the same volume effect during shifts 2 through 4, suggesting that volume alone isn't the issue. It's volume interacting with a high-risk shift. The figure illustrates this relationship for shift 1. As admission volume increases, error frequency also increases, showing a clear upward pattern. This reinforces the idea that risk concentrates when high volume aligns with high risk operational conditions. The takeaway here is that timing matters. Focusing safeguards and resources on high volume, high risk shifts, especially early mornings, may offer the greatest opportunity for improvement. So let's pull all this together and talk about what we actually found from the analysis. First, name-related fields account for the majority of duplicate record errors. This tells us that even with strong systems and matching logic, patient identity still heavily depends on accurate data capture at registration, especially names. Next, morning shift 1 between 5 and 11 a.m. stands out as the highest risk period for duplicate records. That's when admissions pick up quickly. Handoffs are happening, and registration often occurs under time pressure. Timing really matters here. Admission volume also plays a role, but it's a modest one. Higher volume doesn't automatically create duplicate records, but during peak periods, it adds pressure to workflows and makes small data inconsistencies more likely. And our ability to look at timing in detail is limited by the data available. Admissions by shift weren't directly captured, so we estimated shifts based on time of day. That reflects a common challenge in operational data and is something to keep in mind when interpreting these patterns. Taken together, these findings suggest that duplicate records tend to cluster around specific operational conditions rather than occurring randomly.
So let's look at some takeaways from our study findings. What we saw is that the duplicate risk isn't random. It's followed operational patterns. Certain shift in the workload's condition makes errors more likely, which means risk is predictable. And that is really important here because predictable risk can be managed. It's also telling us that monitoring does not have to be broad or generic. If we know when the pressure is highest, we can focus identity checks where they matter the most. Another takeaway is that identity verification has to match the speed of a real workflows. If the process fits the pace of the environment, people will work around it. And finally, system design cannot be ignored operational reality. Technology has to support the way work actually happens, not the way we wish it happened. I want to note a few limitations from our study. We only captured duplicates that were formally documented and reported to us. So there are likely additional errors that never got recorded or detected. We also didn't have a true shift level admission data. We estimate shift based on the time of the day, which is a reasonable proxy, but not perfect. Part of our study period overlapped with COVID, which added unusual operational pressure. That environment actually highlights the risk we are studying, but it also means the results reflect a system under pressure. And finally, our study comes from one regional health system. The patterns are meaningful, but they should be tested in different settings. Looking ahead, our studies open several directions for future research. One area is improving how we measure operational and human factors. Instead of relying only on time of the day pattern, further studies could directly examine staffing levels, interruptions, or workload, and how those conditions related to duplicate risk. Another direction is testing workflow redesign in real environments. If hospitals adjust identity checks during the registration, research can evaluate whether those changes actually reduce duplicates without slowing care. There is another need to evaluate these findings across the different health systems. Patterns may look different in urban centers, rural hospitals, or high volume trauma settings. So, broader replication is important. And finally, for our informatics audience, AI assisted identity matching use real time duplicate detection tools studying how they perform and how they fit into the clinical workflow will be an important space for informatics research. So in the end, we hope this presentation offer a different lens for thinking about duplicate records, not just about the technical cleanup issues, but as the real data quality challenge tied to everyday operations. For those of us working in health information and informatics, there are still important works ahead of us. Connecting workflows, human factors, and system designs so identity risk is managed before error happens and the spread. Thank you for listening, and we love to hear your thoughts and the questions. But before that, let me share few selected references we used in this presentation. If you are interested in this study we presented, we had this paper published, provided here, the last item, that's the publication related to this study. Thank you.
Thank you both very much. The chat has been very active today. And so I'm going to start at the top. Even though, Dr. Harris, you did address some of this, it would be good to get your response to that question and all the others onto our recording. So the first one is about the master patient index. First, for those who are unfamiliar with this, what is it? Is it a national registry? Is it something that is unique to a particular place, that is an enterprise approach? Let's start there.
Yes. So from my experience working in patient identity management, the MPI, it is enterprise. So it's based on a health system, which typically involves multiple facilities within that health system. And a lot of health systems, whether small, medium, or large, they're opting to go the enterprise MPI route because it will allow patients to be seen within that health system regardless of which facility they visit. So if they go to facility A, they can still go around with the same MRN number instead of having separate ones. So a lot of hospitals are implementing that to also minimize patient misidentification issues.
How let's just take a sidestep here. How does that fit into the health information exchanges where you may have more than one enterprise system trying to connect to be able to share patient information? Does the master patient index have a role to play outside of the enterprise?
So I'm going to add a little bit, but I may have Dr. Hauser join in as she's more informatics based. But from my From my experience, there will definitely need to be standards followed to ensure that all of the systems are meeting those expectations because you have so much information flowing from one facility to the next. So ensuring, data governance policies there is critical, in making sure that those standards are being met. Dr. Hauser, do you have anything else to add to that?
No, I think you answered it. But is that true? The master patient index is by the organization. So each
Yes,
organization set up their own because you did
the
that work
enterprise.
in the hospital. Yeah.
Yes.
Mhm.
So yes, I think this is important issue that for interoperability, when you want to share information across the hospital, that if you have a different system, they may not speak to each other. Yeah.
I will say that AHEMA and many other health information organizations, they are heavily advocating for a national patient identifier. And this would allow each individual and nationally to have an identifier that will identify them. But there are a lot of concerns, a lot of controversy around that. But national organizations are heavily advocating for this, as this would also be helpful in addition to those enterprise MPIs.
Okay. There was a follow-up question asking if biometric data has been employed in these identity systems. Has anybody done that, and what are your thoughts about trying to incorporate that?
I have not personally worked at a hospital with biometrics, but I have known several organizations across the country to implement biometrics. And, having this technology, it takes away a lot of the manual processes that are involved in patient registration, and it allows for patients to be identified with whatever identifier, whether it's fingerprint or retina. And throughout research, I have found that a lot of organizations have praised this technology as it heavily mitigates the patient misidentification issues.
So part of the challenge, of course, is not just the duplicate record exists, but there was another question about, well, what happens if a person, let's say, is admitted on an inpatient basis from the ED? And of course, nowadays, patients have arm wristbands to be able to identify them. But does this duplicate record issue follow the patient if they remain at the hospital for some extended period of time?
It could, yes, it could very well follow them. And from my experience, what I've seen when a patient is registered, well, before organizations start implementing the fast track processes where the registration is completed in the exam room, they would collect their information. So prior to them receiving their armband, their demographics will already be in the system, which would cause the duplicate errors. With this particular hospital where we did the study, with them completing registration within the exam room, I don't know at which step their armbands were provided to them, whether they still received them at the point of admission
Mhm.
or after their exam. But being they were already in the exam room, I would have to assume that they already had their armband. So that's definitely something to look further into.
And what about a returning patient? That is someone who perhaps had been seen in the ED
Mhm.
a week, a month before.
Mhm.
Um, did you look at the issue of connecting them to an earlier patient record and any kind of data quality issues in that process?
Not for this study, no. But it is an issue when they return. So if they have and this goes back to the process that patient registration clerks should be following upon the patient's admission. They should be reviewing the MPI or the EHR to see if the patient was recently seen, and they should be asking the patient for some form of identification, whether it's an ID. But that goes back to the biometrics. If they have fingerprint scanning or retina scanning, they can accurately identify that patient versus only verifying with what's in the MPI.
Okay. So we have another question, and this one is also kind of a larger frame. With many small rural hospitals closing, were the test hospitals where you were conducting your research large institutions, urban? Did they have a mix of different sizes of hospitals in their network?
So they were small and rural. And that was one of the limitations that I was able to identify quite early because they didn't have as many options for reporting that would have allowed me to have more robust data and analysis. So, moving forward with future research, it would definitely be recommended to have more of an urban, larger health system with more robust reporting capabilities.
To add a little bit to the hospital settings, those two hospitals, um, Hospital B was merged to Hospital A. That's the Hospital A is larger, and they just merged. So there is another study we did based on the merger, but that's not the topic for today. Is how do you merge four EIHR systems
Hmm.
brought together? But we'll talk about in a separate topic.
So, did you consider, or do you think you want to consider the impact of these duplicate records and the errors that they introduce on the one hand the quality of clinical care, and on the other the cost that they must add?
Absolutely. Uh, and and that's one thing that organizations they don't see that, when they continue to conduct care with all of these errors within their systems, they don't see the actual back end costs that the errors are contributing to. So it would be, great to further analyze that as to and actually pinpointing how much is actually being spent within these organizations with high error rates.
I mean, if you can get the bean counters on your side, nothing will stand in the way.
Yes.
Yeah, we actually addressed that as a future study. Um, but that takes somebody who has specialized in the finance or to look at the cost. That would be interesting to look at.
So we have another question about the duplicate patient records and the errors that they produce. Could this cause patient concerns when someone else's data is entered into their record? I mean, as a patient, should we be concerned about this?
Yes, and this is the flip side of this. So we always focus on what we as healthcare professionals can do, but the patients also should be educated on, what is a duplicate record and what are things that we as a patient can do to minimize our own records from being duplicated. And that's not widely educated within healthcare organizations. So every patient should definitely be aware of those risks and being educated on tips such as showing verification, not providing a nickname at the point of admission, because a lot of patients will do that. If you were married or and now you're divorced or you
The
know
name changes.
yeah, name changes, you need to let them know that. so your own information will not be entered incorrectly. And I saw that Ed made a great comment. When someone else's information is entered into a patient record, that is an overlay, but that is a completely different
Mhm.
study. But that's another type of data entry error outside of duplicate records, a overlay, which is even probably, I don't know which one is worse, duplicates or overlays, because with the overlay, another patient's information is in your record that can potentially be a safety issue for patients.
Sure. I think that's yeah, one thing to point out, that's a privacy issue. Yeah, I don't want my information be on somebody else's records, vice versa. I don't want to say others' information on my record. Also, besides privacy issue, it's also from clinical wise, if I don't have my health information accurately documented, that's bad consequences for my health care because I don't have a full information.
Have you considered a larger related issue? Um, Many clinical studies use de-identified data, and presumably each record is got a unique identifier for the purposes of that study. But if the record set includes duplicates, then it may be that we are inadvertently introducing some data quality issues for large clinical studies where um, duplicate entries for a particular person might skew the results slightly.
Mhm.
Well, I
Yes.
think, yeah, Shannon, you want to say, but I think that's a really important issue. So now you just raised another concerns. In addition to everything we list, the bad consequences, we have to add that one. It wasn't revealed when we were talking. Yeah, to the impact on clinical trials and other research studies to provide those accurate quality data. So back to the original concerns we have.
So we have a question just came in. Um, what are these databases like? Isn't there a primary key to identify each patient?
Not necessarily. Every organization is different. But most commonly, you want to be able to identify a patient with a name and a date of birth, but that's not always consistent across the board, which is why these duplicate errors are occurring, and which is why a national patient identifier would help in these other uh, different policies that we're trying to advocate for, like the Match IT Act. It will allow organizations to create a standard that will allow for universal identifiers to be used when identifying patients. So as of now, organizations have different identifiers that they have agreed upon to use to accurately identify and match their patients.
So maybe you've not looked at this in any detail, but in proposals of national patient identification systems, what kinds of data would be included? And how would you know that the person who offers, let's say, their ID card is really that person?
Yes, I have not looked at that closely, so I cannot speak to that at this moment.
Okay. And Dr. Hammond makes the point in the chat that we are the only developed country that does not have a universal patient identifier. I can attest to that because in Senegal, I asked about this issue and they all pulled out their ID cards and said, everybody in the country has one of these. Why don't you?
Yes. Wow.
Let's make another, yeah, another study or promote uh, patient identifier, unique patient identifier.
Okay. So there are also a number of comments thanking you for this presentation. This was very interesting, and I think we have run out of questions. But thank you
Thank
for
you so
presenting.
very
Well, thank
much.
you. Thank you
Yeah,
very
we
much.
really appreciate this opportunity to
Okay.
speaking here.
And I will now declare the session at an end. Thank you very much for today.
Thank you.
Thank you.